Good morning, everyone. Happy Friday. We are continuing with our very exciting month of uh, presentations related to low barrier care for people living with HIV. And I am excited to introduce our moderator, who I think a lot of people know, but really has been one of the most fabulous people to work with, and that's Jordan Silva, who's now been for 2 years at the Owen Clinic as one of our really fabulous social workers. Prior to that, Jordan was at the AVRC with us working on a lot of different research projects, and also has a really big footprint in the transgender and non-binary community, helped creating some guidelines about best practices in collecting data on transgender and non-binary individuals. But in this presentation, they'll be doing something else. I just wanted to make sure everyone knew because they're so great. But Jordan's going to moderate and keep an eye on the chat. But welcome everyone, and I'll turn it over to you, Jordan.
Thank you so much. Yes, it's lovely to have you all today. Feel free to put any questions in the chat. We'll make sure to monitor and ask them as we go. And with that, I'll just introduce Dr. Mary Hawk. So her work has been driven by a commitment to social justice and the elimination of health inequities. As a nonprofit leader, she's helped to create community-developed interventions and now partners with these and other organizations to do research and replicate meaningful public health programs. Her research foci include implementation and assessment of structural interventions to improve health outcomes for oppressed populations, including those with problematic substance use and substance use disorders. Program evaluation to enhance service delivery in health and public health settings, and the development of community-engaged approaches to optimize public health. She is the principal investigator of an NIMH-funded study that explores the impact of a financial management intervention on antiretroviral treatment, HIV adherence among unstably housed people living with HIV. In addition to identifying novel ways to improve adherence, the study elucidates how representative payee services can be tailored to incorporate harm reduction and the client-centered care. She is also an MPI of an NIDA-funded study investigating experiences of stigma in healthcare settings by people living with HIV who use drugs. She is a co-founder of the Open Door, Inc., a harm reduction housing program created to improve health outcomes for chronically homeless people living with HIV who have untreated serious mental illness and harmful substance use. In this work, she published the first study to explore viral suppression as a measure of housing program effectiveness. And finally, she is an MPI on 2 training grants, a D43 training grant that seeks to increase research capacity and infrastructure among junior psychiatrists in India, building on the research domain criteria framework and the consolidated framework for implementation science, and a T32 training grant titled A Training Program to Address HIV-Related Health Disparities in MSM. And with that, the floor is yours.
Thank you for that introduction. I'm sorry I made you read such a long thing. I wasn't thinking about that when I sent in my little bio sketch, but I appreciate that. It is an honor to be here. Thank you so much for all of you showing up so early today. I'm excited to share our story about our harm reduction housing program here in Pittsburgh, as well as some of the research we've been conducting along the way. So this is the story of the Open Door. This is a housing program in Pittsburgh that was founded by a group of friends who were working in HIV services for quite some time. And we were celebrating the fact that people with HIV were at last starting to live with the disease, but also despairing of the fact that chronically homeless people who use drugs continue to die at alarming rates, literally in the shadows of 2 excellent healthcare systems here in Southwest PA. So these individuals became our target clients, people who were excluded from housing and care because they actively used drugs, could not or did not want to meet the criteria for housing that was so common at that time. Some of you may remember this if you've been in the field for a while. Housing programs used to require people to be, quote, clean and sober for 90 days prior to move-in, which is virtually impossible, especially if you're street homeless, but also not even desired by everyone who uses drugs. So we did a few things back in 2005 to try to fill these gaps in care. First, we asked clients whose needs weren't getting met what they wanted, like why services weren't working for them. There were some good housing programs, but we had people who remained houseless. So this included talking with a group of chronically homeless men with HIV who were living in the back of an abandoned church that had been privately owned by, a less than desirable landlord, but it was housing for them. It wasn't the best accommodations. But what they appreciated from this situation was that they had their own apartments. They liked having a communal living space where they could support each other, and they liked that they didn't have to stop using drugs to live there. Of course, as with many unstable housing situations, the house burned down. This was not sustainable. It could only house a few people. It was not everything, right? So we advocated for other housing programs, including one I was affiliated with, that were meant to serve this population. We asked them to adopt a harm reduction model of care. It didn't go well. One person said, you can't house people who are using drugs. What if someone drops their crack pipe and the house burns down? This is not only not harm reduction and not person-centered, it is stigmatizing. So finally, after a lot of dead ends and much angst, we bought an apartment building and started housing people. It was literally that, loosey-goosey. Initially, the building was owned by two of our founding board members. A short time later, our nonprofit bought the building from them. And this is how the program works. People do pay low rent to stay there. This is because we could not buy the building outright. We had a mortgage on the building. Having people pay rent allows us to keep our doors open. But our core elements focus on harm reduction. Our primary service is to house people. We house people and then work on other health issues after that. We like to, part of our premise is that we value people, not in spite of what they bring to the table, but because of what they bring to the table. It's a whole person, valuing the whole person. And we're really just trying to reduce the hoops that people experience when they try to access healthcare, even in a small city like Pittsburgh. So I want to take a moment just to talk about what this means to practice harm reduction in a housing program. When we talk about harm reduction, many people think that we mean structural interventions like providing fentanyl test strips or syringe services. But harm reduction is also relational. It has to do with the way we interact with clients, supporting people's choices, even when they don't want to stop using drugs, helping them use drugs more safely. Frequently, we hear providers who say they're offering harm reduction services, but what they mean is that they're sort of harm reductioning people until they stop using drugs. That's actually counter to harm reduction. Our whole premise is that we're supporting people's choices. At the Open Door, this also means that we support them in maintaining housing without the expectation that they will stop or even reduce their substance use, in addition to structural approaches like making sure everyone in the building has Narcan and knows how to use it. So, the building had been operating on a mostly volunteer basis for about 6 years. In 2001, I randomly found myself in a doctoral program, which is a story for another time. But I was in a manuscript writing class and decided to write a paper evaluating the Open Door. This was a tiny unfunded study using data available to us at the time. We were very much operating on a shoestring budget and collected very little evaluation data. But we did collect viral load data from the start because this was just a huge health literacy discussion we wanted to center with our residents. So as you can see, this tiny study only had 25 people. This is the number of people who had, on whom we had pre and post viral load data. Many people come to the housing program with no current engagement in healthcare. So we had no labs available in these cases. As you can see, we had 7 people virally suppressed of the 25 at baseline versus 18 at follow-up. This was, more than 10 years ago. At the time, other studies were showing viral loads in similar populations ranging from 16 to 32%. So this felt like a huge win for us. The median time it took people in our program to reach viral suppression was 116 days. And remember, this is providing no new medical services. It was really just housing and peer support and harm reduction care. So next, we decided, now I'm really in academia, so we're writing more papers because that's what you do when you're an academic. But we wanted to understand what it was about the open door that was working for people. So we decided to do a qualitative study with current and former residents of the open door, specifically seeking people who had left the program not very happy, like it's not for everyone, right? So we weren't trying to cream the results. We were trying to get the full picture of the open door. So our research question was, what aspects of a harm reduction supportive housing program do consumers view as being important to their clinical adherence? And we did qualitative interviews with 19 individuals. We gave them a low incentive, I think it was $10 cash to participate. And this is what we found. So first, people talked about changes in their drug use, which was stunning to us because that was not a condition for their maintaining housing. But people would say things to us like, before I lived at the open door, the drugs controlled me. After living at the open door, I control the drugs. And that felt like a huge win for us. That is harm reduction. People can decide if they want to keep their drug use, but the drugs aren't running their lives. It's functional drug use. So that was very exciting to us. People also talked about their sense of independence, positive feelings associated with living in a housing program. And in talking through mechanisms that help them get to viral suppression, they talked about the value of community supports, or the value of community and direct supports. Like, we would help them get bus tickets. We'd give them bus tickets so they could get to healthcare. We'd help them navigate care. Having peer resident monitors was really important because they can help model how to be an advocate for your own healthcare, even when we experience stigma and racism. But the main surprising finding for us was people talk about representative payee as being a critical component of the services that we offered. So some of you may know that representative payee, or rep payee, is a longtime policy of the Social Security Administration, in which some people who have Social Security entitlements, like SSI, are deemed to be ineligible, unable to manage their own funds, and are assigned to have someone manage their finances. This is a rep payee. Because we had a hefty mortgage on our building, the way for us to keep people housed and to keep our doors open was to have them pay low rent to the nonprofit. However, we acknowledge that asking people who are chronically homeless to start paying rent felt like setting them up for failure. So we asked them to allow the nonprofit to serve as their organizational rep payee. This was optional, but of course, we're providing them housing. So I have to be honest about the fact that there was a power differential there. So even though this was not mandated by anyone, I'm sure to our residents, they felt some, unintentional pressure to participate. In the beginning, no one really was excited about having a rep pay. Almost everyone said they would give it a shot. And then when we did this qualitative research, we found that people said that having a rep pay was the thing that enabled them to focus on their health. And several people literally said that having a rep pay saved their lives. Just shocking to us. So here's a short quote by one of our participants of this qualitative study, who talked about the fact that sometimes when you get SSI, you get a lump sum if there's a back payment, like it takes them a long time to approve you. So she was talking about the fact that if she had all that money at once, she thought she would use it all on drugs, perhaps overdose. And having a rep pay helped her to use her money incrementally. And here is a even stronger quote, which I'll give you a second to read because it's longer. So this is really interesting to us because we felt like having the rep payee program was a means to an end, just a way to keep our program running. But this person is saying that actually they had pride in their money management by having a rep payee involved in their bill payment and financial decision making. And I think two things are happening here. One is that I think that when people are unhoused, they experience a lot of stigma and bias related to being unhoused. So when they have housing, they experience less of that. But also our model of rep payee engages people in financial decision making and skills building. So they become part of that process. They feel like they're part of the process. And this is counter to the traditional model of rep payee, which is very top down and sometimes even coercive. So at this point, we realized that we wanted to explore if it was possible that if giving people housing could reduce homelessness, then perhaps giving them rep pay services could help prevent homelessness. So now we're in 2012. We've been operating on an all volunteer basis for about 6 years. We wrote a multi-year grant to our friends at AIDS United, and with that, we were able to hire our first paid executive director, as well as to expand our rep pay services to people with HIV who were unstably housed but not living in our program. We did another small, tiny study to explore the impact of rep pay on viral loads of clients. In this study, we only had 18 people. Again, these are people not housed at the open door, but simply getting our client-centered rep pay services. At baseline, 39% of our study sample was virally suppressed, versus 89% being virally suppressed 6 months after getting rep pay services. Not the most controlled sample or study, but we thought enough to investigate further. And you can also see here that of the 11 residents who were not virally suppressed at baseline, 9 were virally suppressed at follow-up, which was pretty exciting to us. Became the basis of a large RCT study through NIH. Funded through NIH. In the first aim of this study, which we're wrapping up now, we're doing final analysis now, we're conducting an RCT to test the effect of client-centered rep pay services, this new model of rep pay, on ART adherence and viral load among people with HIV who were financially insecure and unstably housed. Our second aim, we're testing the mechanisms of rep pay that might contribute to changes in adherence. And finally, we're doing a cost and cost effectiveness assessment of the model. It has been challenging and laborious, but also very exciting. So you can think of this slide as almost a logic model. In the short term, we're assessing the degree to which we're able to assure rent and utilities are paid for our study participants. We're also measuring the amount of contacts that our participants have with providers, because we suspect that that may be part of the mechanism that improves people's adherence. Because if you're talking to someone about your money management every month, that's already increasing your contact with your providers. We're also exploring connections with providers, subjective connections with providers, because we want to make sure that this is a positive thing, a positive experience for participants of our study, and not in any way coercive. In the midterm, assessing a lot of things here, experiences of financial and housing stability associated with our client-centered rep pay model, self-efficacy for health behaviors, specifically self-efficacy for adherence. We're assessing changes in participants' quality of life, retention in care, self-reported adherence, medication adherence, and also clinically assessing CD4 and viral load for our study participants. In the long term, we're hoping to reduce HIV health disparities, to improve viral suppression rates for this very marginalized population, and improve rates of secondary infection, HIV infection. But I want to leave you with a few ideas about this study. One is that homegrown work is really important. I think we need to think more about incrementalizing up large RCTs, big NIH-funded studies, because we would never have come up with this model if we weren't listening to the people we were aiming to serve. So small studies, we think, can lead to big things, and certainly community engagement is key to public health interventions that work. But I also want to acknowledge our privilege. Again, our one friend who was one of our founding board members had an aunt that died that left her a small pot of money that was our down payment. That is privilege. Not everybody who wants to start a housing program, is going to have access to that pot of money. So rest in peace, Aunt Sue, and thank you for your help getting this program going. I also want to mention that this is really, really hard work. And I feel like often when we're talking about research outcomes, we make it sound like it's shiny and happy and it was smooth sailing. It has been anything but. It has been traumatic. It has been hard for people who live in the program. It's been hard for people providing direct services to residents of our program. But we've housed hundreds of people to this program, and help people to feel more connected, and certainly help some people to stay alive. So we're really grateful to have that opportunity to do that with them. And of course, housing is critical and should be a right, but it's honestly not enough, because people who are living in our program continue to experience racism and stigma and trauma of lives spent in houselessness. And even when people are stably housed, they continue to experience these stigmas and biases and the effects of policies that work to keep people with criminal histories out of care. So we need to do a lot more to work towards a cultural shift in the way we serve people who are houseless, people who use drugs, and people with HIV. And that's about the end of my slides, but I want to add a shameless self-plug here. I'm sharing a QR code here, which will take you a link to one of our papers that we published, which is titled Harm Reduction Principles for Healthcare Settings. In this paper, we seek to operationalize ways that providers can offer harm reduction approaches to care, even when you're working in settings where syringe services might not be legal, where maybe you have policies that keep you from offering people Narcan. It's a free way to improve ways that we relate to people who use drugs, and ways that we can improve outcomes for these highly oppressed and marginalized populations. And it's free. So, I mean, the paper is free, but also this way of interacting with people is free too. So this is a huge part of work that we're doing at the Open Door in our CCRP study and in that NIDA study that Jordan mentioned in my introduction, in which we're exploring the impact of harm reduction care on stigma experience in healthcare settings for people with HIV who use drugs. I'm going to stop talking. Thank you all. I can take any immediate questions now, unless, Jordan, you prefer we wait to the end of CJ's talk as well.
I think we can open the floor for any questions. Feel free to unmute yourself to ask, or you can put them in the chat.
Hi, Thomas.
Hi there. Thank you so much for that talk. It was really inspirational to see the massive change you made in your community. You've clearly had quite a lot of success engaging the research community with your findings. What success have you had in terms of engaging political will to make changes in your community, though?
You know, I think that's a great question. I think that in the, how many years has it been? You know, it's been over a decade since we started this work. Harm reduction overall, I think, has become more, the term is more commonplace. So we're seeing a shift in acceptability of harm reduction in many political settings for sure. In our city, there's been much more acceptance of harm reduction. I believe the Open Door has been part of that process. I will admit that in the beginning, even though those of us who started the program were working in HIV settings, and I think fairly respected by other healthcare providers, they thought we were crazy. And I don't mean to use that like stigmatizing term crazy, but they thought this was ridiculous that we would try housing people and supporting them in their drug use, not encouraging their drug use, but supporting them in their drug use. And honestly, even though, you know, two of us who founded the program randomly ended up in doctoral programs and ended up doing research on the Open Door, although that was not part of our plan, I think that was key to building credibility for this approach. So I think the research was part of that building political will. We have not been actively involved in advocacy for harm reduction except through other providers. And of course, we collaborate closely with our syringe service program and help them in their advocacy roles. So we have seen a shift. I'm not sure that we can take a lot of credit for that shift, but I do see that the Open Door has become a model for harm reduction care in our city. So I think we've contributed in small ways. Does that answer your question a little?
Well, it does answer it a bit. I guess when I say engaging, have politicians been persuaded to stump up the cash? I guess is the ultimate question, isn't it, to help with these things?
No, politicians have not. Our continuum of care, our housing continuum of care has broadened, and SAMHSA, now offers harm reduction as an important approach to providing housing. But no, our political servants are not. They have not ponied up for sure. Some questions in the chat.
We do have a few questions in the chat.
Yeah.
So first from Nettie, how long could people stay in the building? Was it indefinite? And what were some example longer term outcomes for residents?
Yeah, so we did not want to set a limit for people staying in the program because we know that people, we tried to prioritize services for people who would not be served through other programs, people with criminal histories who wouldn't be able to get Section 8 or subsidized housing programs. But we also knew that, so we didn't want to, throw them out at any point after 6 months, whatever. But we also know that there are some housing programs that you have easier entree into if you're in a transitional housing program first. So we deemed ourselves a traditional model of care. One thing that our peer resident managers who themselves are either living with HIV or in substance use recovery or both started from the beginning was from the onset. When someone moves into the program, they help them start working on other housing options, which ideally are funded, so they don't have to pay rent or pay even lesser rent. So there's no hard deadline, but for moving out, I will say that even when people aren't happy in the program or aren't a good fit with the program because they're violent or not interested in improving their health or outcomes, no one is thrown out, but they are asked to leave and help to find other housing solutions. So it's still very person-centered when people leave. Longer term outcomes, we have lots of people who move out, maintain independent housing, manage their own funds. I will say that a test of the rep pay model is that lots of times when people leave the program, they keep the rep payee, which they certainly don't need to do. People move out of the city, keep the open doors, the rep payee. So pretty interesting longer term outcomes there. I see another question about what rep payee does. Yeah, so the way this works, we're following the entire model of Social Security, which is that we're formal rep payees, right? So how that works is that when someone is deemed as your organizational rep payee, that rep payee sends up a bank account for them, and their entitlements are deposited in the account, and the individual, the beneficiary, doesn't have direct access to the account. Instead, the rep payee works with them to determine what bills they want to have paid and takes care of paying those bills. Our rep payees also work directly with the client to figure out how else they want to spend their money. That includes conversations about how much do you spend on drugs in a month? How can we make sure that you have enough money to cover your drugs for the month so you're not engaging in risky activity to make sure you have enough funds? Like, it's a very harm reduction, client-centered care. And I bet Social Security would not love that conversation about using entitlements to pay for drugs, but it is harm reduction.
And
I can also share after this. I don't want to dig into CJ's time, but we have a rep pay toolkit. I'd be happy to share.
Okay, that's exactly what I was going to ask. Thank you.
Yeah. Jordan, do you feel like I should stop talking and maybe answer questions offline just to respect Jordan's time?
Sure, yeah. We can kind of definitely come back to this if there's enough time at the end for sure.
Okay, and if not, I'll share contact information and maybe engage in more answering of questions after the talk. Thank you so much.
Wonderful, thank you so much. And so our next presenter is going to be CJ Tobe, who has lived professional and academic experience in the field of HIV and STI prevention and prevention education. As a person living with HIV, CJ has dedicated his career to eliminating system barriers to improve access to healthcare and social support services for those living with and at risk for HIV and STIs. In his capacity as Chief of Community Health with a master's degree in organizational leadership and 9 years of work in HIV care and prevention, CJ is steering DAP Health's expansion for sexual wellness services. Under his leadership, DAP Health is eliminating cost and access barriers for sexual wellness services by offering free HIV/STI testing, both clinically based and in a mobile unit. Strategically located in communities in DAP Health's service region, challenged by high HIV and STI prevalence and incidence rates among populations of Latinx and men who have sex with men. CJ has led the development and implementation of a California certified mobile harm reduction program, as well as initiated DAP Health's partnership with MR to expand access to HIV prevention medication, or PrEP, and HIV care virtually across the state of California. And with that, I'll give him the floor.
Thank you so much, Jordan. Happy Friday, everybody. It's a pleasure to be with all of you. And I'm joined by one of my new colleagues, Dr. Jason Halpern. Good morning. And then La Bianca, the executive assistant, is going to be doing air traffic control for me because I can't multitask. It's the one thing I can't do. And so I typically like to start presentations with kind of a moment of like gratitude. And so I want to share with you, I don't want to say I celebrated, but I just had my 13th anniversary of my AIDS diagnosis. And also 10 years where I was unhoused. I moved from Ohio to Palm Springs with nothing and spent many nights homeless and doing everything I could to survive. And I know that the work that you do is stressful, it is tiring, and sometimes you want to give up. But I just want to say thank you for everything that you have done and will do in the future to give people a second, third, and fourth chance to live their healthiest and happiest life. So I just want to say thank you for making the time today to join Mary and I's conversation about amazing models to support our unhoused population. So with that said, next slide, I'm going to talk to you about DAP Health's housing model. And we're going to go over different topics there you can see. It's not just going to be about housing because I have to give you the full picture of the organization and some of the history to kind of show how we leverage what we've learned through 40 years of service to create effective housing models. In that slide, you'll see our mobile unit. It's a mobile clinic. It's licensed and it's doing HIV, Hep C, and STI testing. But specifically, it's focused to the unhoused population. And it's doing a harm reduction program, so overdose prevention. We're looking at fentanyl testing strips and Narcan naloxone, but also syringe services. It's out 5 times a week, specifically to the unhoused population. And just to share a quick story with you is the team encountered an unhoused person at an organization doing an event. It was probably about a year ago now, who's been out of care for HIV for 3 years. And it took them 30 minutes to convince this person who was unhoused with their shopping cart to get a Lyft ride to the organization and put their shopping cart into the mobile unit and bring it back to campus because they did not want to leave everything that they have in that shopping cart. And so we were able to get them into our free STI clinic for rapid restart. They're currently enrolled into our outpatient drug-free program. So that's just something I wanted to share with you as far as like what that mobile unit does. It's small, but it's powerful. It makes a huge difference. Next slide, please. And so here's just a brief timeline of the history. We were actually founded in 1984 as the Community Counseling Center. And then we became Desert AIDS Project. And then now we're DAP Health. And so when you look at the history, what's so unique about it is the first 9 or 10 years of the organization, we didn't have medications to treat HIV and AIDS, which you're all aware of. So it was creating systems and alternative strategies to be able to support people's health and well-being and improve their immune system. And that's what I find so unique about the organization is it's not just the medical, but it's the holistic approach of everything that goes into making people's life their healthiest and happiest life that they can be and improving that immune system outside of medication. And so when you go through this timeline, you can see different responses and different expansions. But the one I definitely want to share with you really is just what recently happened, which this presentation is not going to be about because we just closed on August 1st with the acquisition of Barango Health. And it was the largest FQHC acquisition in the country's history. We went from serving 10,000 patients to 130,000 patients overnight. And so Dr. Halpern joined us and is going to be a huge leader in my counterpart when it comes to meeting the unmet needs in the community across Southern California. Next slide, please. So here's some services pre-close, right? DAP Health of what we were providing, and you can kind of see everything there on your screen. I'm not going to go over a lot of it, but I think the unique service that we provide is a sexual health clinic here in Palm Springs and also another one in Indio that we opened a year ago in the middle of the Latino community where all services are free. That's PrEP and PEP services. That's the first 2 visits for rapid start or rapid restart and all testing and treatment you can think of, including birth control and pregnancy testing for women as well. All services are free. We don't take insurance. You complete a form. You don't have to have an ID. It's very low barrier, no red tape clinics. It's been financially sustainable, which we can get on the conversation about financial sustainability anytime you want to offline. But it generates revenue by also meeting that unmet need in the community. And ultimately, it gets people connected to services. It is a gateway for people to walk in, not be judged, to talk about what other services can we get here at DAP Health or through community partners that we're not going to be basically scrutinized or judged for being unhoused or using drugs or being trans or living with HIV. Next slide, please. This goes into more details just about specific services that the Community Health Division provides. Here on campus, I don't know if any of you have been here on campus to the main clinic in Palm Springs, but we have obviously an on-site Walgreens, LabCorp, Urban Yoga, client computer lab, kitchen, I mean, you name it, about anything except optical we have here on site for our patients, clients, and also for our employees. Next slide, please. And so there's another presentation I give when you think about the Coachella Valley and you're looking at it flying in from the 30,000 foot level. It's beautiful, right? You got palm trees, and I'm sure San Diego may be the same for you, but Coachella Valley, it's even prettier. And it's amazing, but once you actually get on the ground and you start going into these communities, you see the significant health disparities that exist. And so that's something that we really like to talk about, the Coachella Valley. It's not just a place for people to come to retire or get that weekend getaway. There's a lot of health disparities in the Coachella Valley. And it shows that nearly 2/3 of people living with HIV in Riverside County reside here in the Coachella Valley, and also 50% of the population is living under that 200% federal poverty level. Next slide, please. So we're going to get into housing services. And the first thing I want to say with housing services, there's so many different things that Mary touched on that was significant. I'm actually glad she went first because it kind of is a great segue into, I think, my presentation and our model. Poverty is really like one of the big driving factors that I think a lot of us don't talk about for whatever reason. I was in a planning committee 2 weeks ago about planning a big health and wellness summit here in the region, and everything just comes back down to poverty, and we get into the reasons why. But I want to share a partnership that DAP Health has done with QueerWorks, which was to obtain money and get involved into a research project where we create a safety net for people that we've enrolled into this intervention. It's called the Universal Basic Income Project. And so we actually give a monthly stipend to folks that meet the criteria to create that safety net so they can keep a house over their, keep a roof over their head, food in their belly, making sure they stay employed, and create that safety net and measure those health outcomes over the next couple of years. So when we look at like the housing services that we offer here at DAP Health, we do have 2 housing structures actually here on our FQHC campus. One has been up since 2007, and one is set to be done in December, and I'll get into that. But we do like emergency housing, and then obviously permanent housing assistance, any kind of utilities assistance that someone may need. And we are able to be very, I would say, very creative in how that works. So if we have somebody who, for example, has to put $300 towards their car for something, we're able to then take that expense and pay $300 towards, say, their utility or to their rent. So ultimately they break even and don't actually lose the money. So we get very creative with how that is structured. Anybody that needs deposits for deposits for rent or first month rent, we obviously help with as well. And then on-site case management that we also provide. And we have housing case managers in our housing structures here on campus as well. The one thing that I think that it makes this unique as well is DAP Health has a resale store called Revivals. We have 4 of them across the Coachella Valley. They bring in a significant amount of unrestricted revenue, and it's all through donations. We do have our own furniture line and also an online store. And so people come, they donate their clothes, we turn around and we resell it, right? And then we do different events throughout the year. We do like leather after dark. And it's for our leather community where we put everything we can't really sell, you know, during the business days, and we do it a big event at night, and it brings in $15,000 in 40 minutes. It's super, super helpful. And it really, you know, reaches out to the community. But the great thing about DAP Health Revivals is we leverage Revivals to get materials for people who are unhoused. So whether it's clothes, whether they need a kitchen table or a bed when they move in, we're able to then leverage that resource through Revivals to help support our unhoused folks. And we partner with them a lot. Anytime there's a change of season with our mobile unit, we'll bring racks of clothes, boxes of hats, socks, kids' clothes, you name it, to make sure that everybody's taken care of as well as far as clothing. Next slide, please. So here's a list of our housing partners, and one housing partner that I didn't include on here because it's new, but we just got awarded a SPINS grant. It's called Sure Housing. through HRSA. And so we're currently hiring staff for that to see if that intervention works, where we rapidly house people through outreach and case management. So that's something that our housing department's currently working on. And then partners to basically make Vista Sunrise 1 and 2, which is our on-site housing complexes, come to life. And you can see Mary said the same thing. You can't do anything alone. You got to have partners. And so these are our funders and our partners to make these housing structures happen here on site. Next slide, please. And then so written health outcomes. So here's the average stay at our first housing complex that opened in 2007. People stay there for 7 to 10 years. It's permanent supportive housing. There is a waiting list for years, right? We're like everybody else. We need more housing. And the average range of monthly rent per client, it's all income based. And so it's anywhere from $535 a month to $948. And then this was as of August. Sorry, I don't have September's data, but all 80 plus folks that are currently living in our Vista Sunrise 1 housing structure has a undetectable viral load currently, except for one, which had a pending test. So obviously that shows living close to your medical home or on your medical home campus is going to improve the health outcomes because they literally walk across an alley right into a pharmacy, right into the clinic, and they're greeted by volunteers who are also living that journey with them as well. All right, next slide, please. So this is just a picture of our capital expansion. We're in the middle of about a $30 million capital expansion to triple the patients that we see here at our Palm Springs campus. But the reason why we're really doing this, it's really to meet that unmet need of getting more folks into primary care and behavioral health services. And then also to fully integrate the PCMH model where we're meeting, doing morning huddles in the clinics, making sure that the pharmacist is there, the nursing staff is there, case management, the clinician team, the housing case managers, and just really providing that wraparound PCMH model of care here in our Palm Springs clinic. And then the next slide is going to show what Vista Sunrise 1 actually looks like. So you can see that there are no roommates in this. So they're basically studios or 1-bedroom apartments housing 81 folks. We usually have at least 1 or 2 people, either 1 or 2 vacant units just because people move out and we got to get it clean and painted. We have an off-site third-party contractor that essentially runs both of these complexes here on site. And then the next slide is going to show what Vista Sunrise looked like probably about 8 weeks ago. I can tell you now it looks completely different already. We're going to have solar on our parking structure, a housing case manager there. We're going to be offering cooking classes and making sure that people are able to even grow their own vegetables and bring stuff in as well. And the next slide is going to show what it's going to be looking like. It's going to be built for either families and or single residents, anything from studios to multiple bedroom apartments, and it's going to be 3 stories. And obviously there's a pool and dog park as well. It's beautiful. If any of you are ever in Palm Springs, please stop by so I can walk you through and show you this campus, have you meet and talk to people coming in the doors and just how welcome they feel when they come. And when we look at what just took place as far as how I said that we've grown now overnight from 10,000 patients to 130,000. We're going to be spending the next year really doing some data, listening to those consumers in the communities across Southern California to see where we need additional permanent supportive housing by clinical sites. Now that we have over 20, and our CEO will be meeting with those political figures, right? Those ones to start advocating to make sure that we get money either in state budgets or city funds or even federal monies to be able to come to this region to make sure that we invest in infrastructure and housing to support our unhoused folks so people can live their healthiest and happiest life. And I believe that is it. And please ask me or Mary any questions because her presentation was phenomenal. And the floor is yours to ask any questions. It was a pleasure to be with all of you. Thank you.
Thank you so much, CJ. I know we had one in the chat of, do you utilize the 340B program?
We do. We definitely utilize the 340B program. 60% of our organizational revenue comes from 340B. And then the other comes from obviously donations, events, fee for service, a lot of grants. I currently have, I believe, about 13 or 14 different grants, including 3 special projects of national significance funded by HRSA. So grants are essentially my life. But yes, 340B is a huge driver. And when you look at 340B as well, like when you're opening up free STI clinics, right? They're only going to be funded by 340B, right? The PrEP and PEP, the HIV medication, but you can then take those funds to give back to the patients to create housing structures, create the infrastructure to make sure people can have transportation to get to and from appointments, making sure they get food vouchers, right? Hiring case managers to help people get enrolled into insurance. So yes, all of our money is reinvested back into program development directly to support patients. And one thing that we've utilized 340B funding for is any patient of ours that is under that 200% FPL level that has an out-of-pocket copay for medication, we cover it. So we make sure that our patients who are living below that threshold are paying absolutely nothing out of pocket for their medication. Great question, because I could talk 340B all day.
Could you come talk to our organization about why the 340B money that we generate should actually come back to us? How do you think that is something, CJ, you could come and help us with?
Well, that's kind of the purpose of the 340B program is to go back. Is to go back to serve the patients and the people that are coming in our door, that unmet need. So that, I mean, it's a federal requirement that we have to take that 340B revenue and it has to go back to the people that we're serving.
Yeah. Sorry, I'm being a little rhetorical, and people know that we've talked about this before. Anyway, it's nice to hear all of the things that you do with your 340B money.
Thank you. And I would also say, just with 340B for one, would be, I don't know if you're all familiar with business cases, but it's something that I've probably done 100 of them in the last 4 years, and I probably only brought maybe a dozen of them to life. But you do business cases, and you vet either new programs, new clinics, expanding services, and you create this financial sustainability for something new, and you really start getting the data you want about where the revenue is going. And then you're able to say, okay, well, I want to open this new clinic. It's financially sustainable. Here's the revenue streams. And you can look at the amount that 340B is actually bringing into your clinic or your organization. And you can say this money needs to be reinvested to improve the health and well-being of our community. That's exactly what 340B funding is for. Okay, then I got this question.
I had a question. Oh.
Yeah, go ahead. And I'll get the one
Sorry
in
to interrupt. I was just noticed a pause, and I was wondering if you could just talk a little bit more about substance use disorder and substance use in your, you have sort of a village that you've created, and we're seeing a lot of changes even in our stable population that we've been caring for years, with sort of the addition of fentanyl and expansion of methamphetamine use. We're seeing increasing mental health and behavioral problems within our population of people even that we used to know and care for. So I'm wondering how that's happening in your community and how you're managing that with your residents and sort of maintaining stability while also serving that population.
Yeah, that I can give you a long answer to this. So I know there's 3 methadone clinics that we partner with, 30 different recovery centers. There are different residential treatment programs here as well that we have MOUs with, that we do testing, linkage to care, and we're actually going to be trying to do a rapid start for Hep C treatment is another project that we're trying to do here soon coming up. Currently at DAP Health, we obviously have that harm reduction program that I mentioned. We're getting our first vending machine getting installed next Thursday into one of our community partners, and working with the city to get vending machines across the city. We have an outpatient drug-free program. And that's something that I think that has been really a game changer when you look at seeing kind of that behavior change that you want to see, where we have harm reduction that's essentially operating after hours in the same location that our outpatient drug-free program is operating during hours. And so we know people that are in that ODF program may start using again 3 months down the road. And we're now, our communication is, we're not closing our doors on you. We're actually keeping the same door open. You're just going to come in after hours and get services through the harm reduction program. And they're doing a curriculum. It's called Seeking Safety. And then also it's going to be another one focused on ChemSec. So they have 2 tracks right now. The 3rd track we're looking at is going to be specific to either Latinas or pregnant women. And so that's a 3rd track we're looking at adding right now as well. And then Dr. Halpern, we were seeing a lot of Palm Springs patients moving to San Diego for affordable DMC treatment. I'm not sure if you want to comment on that or if you've seen that as well, but I would love to hear more about that.
Sorry, CJ, it took me a second to unmute. I was going to see if Chris, if you wanted to say a little more. You know, we, as DAP is moving now into San Diego County, we have some locations in Escondido and El Cajon that it's going to take me a little bit, but my plan is to make sure that we have really robust MAT programming at both of those locations, at least for the outpatient basis. But Chris, I'd love to hear a little more from your end.
What we're seeing in San Diego is just a lot of people coming here from Palm Springs because, as you know, Palm Springs has a lot of for-profit programs that the majority of our population is drug Medi-Cal Ryan White. So do you foresee any of that in the future of in the Palm Springs area, a residential treatment program?
We do, but the issue is going to be insurance. A lot of them require insurance. So if somebody that doesn't have insurance, so a lot of times it's going to take 30 days for them to get insurance and enrolled into a program. By that time, they've already disengaged. So that's something that I know that we're working on specifically through our wellness department, but also even looking at community partners as well of how to eliminate that red tape and get people enrolled quicker. But yeah, I've actually heard stories too that people have gone either to Phoenix or San Diego for residential treatment.
Something like that would come down the tube.
And there's another question in here about rent. So yes, so people pay rent if that's directed towards me. So people do pay rent. It's anywhere from $500 to $900 a month. It's going to be based on their income. A lot of people that are in our housing structures are on fixed incomes like SSI, for example, or SSDI. So just a certain percentage of that is then allocated for their rent.
Thank you. And I had a follow-up question on that for you and for Mary. Do you think, and it's going to sound a little bit paternalistic, but do you think it is helpful for people to pay rent in the sense that it forces a structure in terms of having to pay that rent and having to organize yourself and having, that like obligation at the end of the month? Or do you think it would be better if it was free?
Mary, do you want to tackle that one?
Yeah, I mean, I appreciate the question. I think it would be better if it was free because people get, less than $800 on Social Security. It's not enough money to live on. We are not providing benefits that people can sustain on or be sustained on. And most of our residents are too unhealthy to have jobs. So I definitely think it'd be better if it was free. I think that, I appreciate what you're saying in terms of having some organization in your life, some commitment. And I think there are other ways to build that. Interestingly, a couple years into our program, our residents created a resident advisory board where they had some accountability to each other. They would garden. It's really beautiful how people can jump in to create those systems of accountability with each other and for each other. Again, don't make it to make it sound so, perfect, happy place, because it's not. If our country provided reasonable benefits for people, then I would say, sure, maybe rent is a useful sort of budgeting skill that people can learn and then take out, elsewhere. But in our current model, I think free would be better.
if there's time for another question, I mean, I know this is not legal in most of US states, but do you think having consumption rooms inside of these housing structures would be helpful?
Is that a question for both of us or for CJ?
Yeah, both.
I mean, I think my answer will be quicker. We are, people have independent apartments within their buildings, so they have their own consumption rooms. And then we do have mechanisms in place to make sure that someone's checking in case they overdose, they can be reversed. So, it's just like any of us here who may be using drugs. I can get high in my home office anytime I want. So that's like my own safe consumption room. And then I can use the Brave app or Never Use Alone to make sure that someone can check on me so that I'm not, or I can make sure my loved ones or, people who live near me can check on me. So that kind of is built into our model. I should also say that we also are building in, like if people want to engage in other forms of recovery, including abstinence-based care, we will connect them and support them. We just don't assume that's the outcome. But I feel like what you're asking is great. And I wish that that is an approach that was legal and embraced throughout our country. We've kind of built that in.
And I fully support safer consumption rooms. I know there was a bill on Governor Newsom's desk last fall to sign it into action, and he vetoed it. So, once the policies and the law gets there, I think it's going to be extremely helpful by keeping people alive.
Thank you. I'm asking because I visited this homeless shelter in Lisbon in Portugal, and they had a safe consumption room for alcohol, for smoked meth, and for injected drugs. And it seemed to help people manage their drug use better, especially it seemed for alcohol, just kind of like sitting there, having your drink. But yeah, I totally see what you're saying.
Well, and if you can go see a medical professional that can even help you, let's say, properly inject, for example. I've had women who were injecting in their neck and in their breast because they couldn't inject it anywhere else. So just being under that medical supervision and those experts to help people would be great for one. But then also just the fact, like, if somebody does overdose or something goes wrong, you're surrounded by medical people that care about you.
Thank you.
Thank you, Mary and CJ. Such incredible work, such incredible talks. I think have inspired all of us, and hopefully this is just the start of more collaborations with both of you and others here in San Diego who could hopefully bring some similar projects here. And Marvin, if you could put the slide up with the link to the working group. So at the end of all of this, this incredible month, we are also convening a working group on low barrier care to bridge, institutional collaborations, share best practices, two of which were shared today, and also, apply for some joint funding opportunities. Please, anyone who wants to be a part of this, use the QR code or email CFAR to join. And we love, Mary and CJ too, for you to be a part of it also. Be great to have collaborations in Southern California and beyond to Pittsburgh. So thank you all. Happy Friday, everyone, and have a wonderful weekend.
Thank you all so much for having us and for the work that you do.
Spectacular talks. Really appreciate it.
Thank you. Have a great weekend.
Bye and thanks.